today's lecturers, Dr. Brostrom and Dr. Bamrah Morris. Richard Brostrom is a CDC TB medical officer for the Pacific region, currently serving as branch chief of the Hawaii TB program. He has worked nationally and internationally in TB control since 2001. Most recently, he helped to install and train 7 programs for new gene expert platforms across the Pacific and led a novel regional response to an outbreak of TB at a small college in Micronesia. He worked directly with the Chuuk TB program over the course of 2 years to improve TB and MDR-TB care, as well as provide MDR-TB prevention. He received a National Service Award for work with drug-resistant TB cases in Micronesia in 2010. Dr. Bamrah Morris currently works on the Field Medical Officer team within the Division of Tuberculosis Elimination at CDC. Sapna completed her residency in internal medicine at Case Western Metro Health and fellowship in infectious disease at the Cleveland Clinic. In 2008, Dr. Morris took a full-time medical officer position with the Outbreak investigations team within the Division of TB Elimination. Since that time, she has been involved in numerous outbreaks with a particular focus on TB in persons experiencing homelessness and in the U.S.-affiliated Pacific Islands. It is now my pleasure to turn you over to Dr. Richard Brostrom. Thank you.
Good morning from Hawaii. I hope the sound is all right. Please let us know if you're having trouble hearing just by adding some comments. It's a pleasure to be here this morning. And we'd like to share with you the experience we've had in Micronesia with a major outbreak, which included attempts to do preventive treatment as well as treat the active cases, of course. We've divided this into 4 sections: the epidemiology and background. We'll talk about the outbreak response and the treatment of contacts. That will be led by Dr. Bamrah. We'll both share the findings from our observational cohort study. And then I'd like to administer an informal MDR-LTBI poll. So we hope you can stay on to the end because we really are interested in what your opinion will be there. So here's the U.S.-affiliated Pacific Islands region. It's a large area. These are all clusters of islands that are underlined are associated with the United States, part of the 22 island nations of the Pacific. Beautiful, very different from each other, and wonderful places to work. TB is a big problem in the Pacific, particularly in the U.S. affiliated islands. And in 2007, Chuuk Island, which is part of the Federated States of Micronesia, reported 2 MDR-TB cases. Actually, the genotypes were quite different, and the cases were unrelated, although they were both on this small island of 15,000 people. One of them was a 5-drug-resistant strain, the other a 3-drug-resistant strain. This was the first MDR that Chuuk had ever seen. We did have other cases of MDR in the Pacific, in Guam and in Saipan, as well as in the Marshall Islands. The first 2 cases were initially reported to CDC, which doesn't deal with second-line or first-line drugs with our regional grants. And WHO, and the program had a hard time completing all the forms it needed for Green Light Committee access to second-line drugs. Consequently, the MDR-TB patients were sent home while the program attempted to get the proper medications. 4 of the first 5 cases of MDR died in a short 8-month period. Included with them were a 2-year-old and a mother with MDR, and overall, in the end, it took more than a year to acquire effective second-line drugs. The program, like many programs that have MDR cases, were struggling. They were overwhelmed, understaffed, and had no MDR treatment experience. On top of that, the island is probably the least economically developed in the Pacific. With fragile infrastructure, power, water. I wish I could sort of show you or take you there. I'll show you a little bit. This is the typical residence in the U.S. affiliated Federated States of Micronesia. This is actually the main road. There's the recently donated ambulance, which is now on the blocks, and that's the hospital that you see in the background. Here's the ICU. And here is inside the ICU, where you bring your own pillows and bedding. Some of that equipment on the left there works, and some doesn't. There's no air conditioning. It's open air. So it's a tough place. And what happens when you have 2 MDR cases and they don't get treated for a year is you end up with more. And in the end, we had 41 cases of drug-resistant tuberculosis in addition to our contacts. Despite some well-intentioned advice that we could not achieve treatment on such a difficult place, we did work exceptionally hard, especially the local program, and we did initiate treatment to these patients since 2008. Here's the epi curve, and again, this is what happens when you don't treat MDR quickly. And you'll notice there on the right side of that curve, there's some blank spaces, and that is a sign of both the success in treatment of our cases and our prevention work, we think. It's also important to note that just the epi curve doesn't really tell the story. This is what I call the treatment curve. So these are the number of patients who are under treatment at any specific time. And you can see the program, which had never managed a case before, within a year and a half, was managing 25 MDR cases at one time. This was a lot of work for a small TB program. You also note that at the end of that curve, you see one patient under treatment, and that patient has actually been discharged. We show this every time I talk about Chuuk because I think it highlights the successes and failures. This young lady on the right, these are a brother and sister. She had a positive skin test and a chest x-ray and an exam that were abnormal. She had a collapsed lung, and she had MDR-TB. She was admitted and treated and has done well. That's her brother there on the left, and he had a positive TST, and his x-ray was done on a film that was so dirty it was almost unreadable. The repeat was ordered and was finally and not completed. He actually presented to the hospital comatose 2 months later and had 5 drug culture resistant or culture positive TB meningitis, and he died the next day. So this isn't about our cases, so we'll go very quickly through these slides, but standard treatment were given to the cases, and the reason I included these slides was just pretty much to show you this one, which is that the treatment success rate was remarkably good. We were really quite pleased with how this turned out. When we look at the expected treatment success rate across the world for MDR-TB, it's under 50%, with a goal of 75% by the end of this year, which most people are pretty sure we're not going to hit. We actually have a treatment success rate of 97% in Chuuk. The program has been amazing. So at this point, well, let's move towards the treatment of the contact. Sapna, can you take it from here?
Okay, thanks, Dr. B, and everyone, please let me know if you can hear me. I'm both suffering with some laryngitis and hoping my microphone will work well. So in actually my second day on the job in the Division of TB Elimination, I was asked to join Dr. Brostrom in the Federated States of Micronesia to investigate what ultimately was 2 distinct simultaneous MDR-TB outbreaks on Wano Island in Chuuk. And as Dr. Brostrom mentioned, although there presumptively had been drug-resistant TB in the Federated States of Micronesia prior to this, these were the first cases that we were able to prove and knew had MDR-TB. And as you mentioned, there were no meds on the island. So this was a unique situation. We had, as the epi curve showed you, a number of deaths right away, and because of that, CDC was able to conjure up quite a team of 8 of us that were addressing everything from logistics and getting medications on the island to a pretty extensive contact investigation that I'll tell you about. So during the investigation, we identified 232 contacts and were able to evaluate them. I want to say right away that these contacts that were evaluated included healthcare workers, where I think we erred on the conservative side and included all the healthcare workers that were involved in any TB care at the time, and in particular of the patients that we knew had MDR-TB. And on the other side of the coin, in terms of household contacts, there were a number of contacts that lived off island that were distant relatives from, I will say, our Western or ethnocentric standpoint. And I think we neglected to understand some of the dynamics around the number of people that may have been in and out of households during the infectious periods of these cases. And so at the time, I don't think we understood the underestimation of the number of household contacts that were potential. But whomever was identified and we could evaluate, we included in that list. After we did the investigation, we identified these contacts. There was a period of time where we were discussing with experts, consultants, and folks here at CDC regarding what should be done about infected contacts of MDR-TB cases. One of the main conversations was certainly with the local program, understanding the burden to both obtain the medications and be able to not commit all of the resources of the program to simply treating these cases when we have a burden of other TB, both pan-susceptible as well as other drug-resistant tuberculosis. We knew one of the key things for the Chuuk program was to prevent future cases, and that was really one of the main goals. And given the situation, we discussed with a number of experts, and we talked about whether or not these infected cases should be treated. At the time, there were a few evidence-based recommendations, the balancing of the risk of treating versus not treating, the feasibility of providing that treatment, and of course, toxicity concerns, both in terms of doing no harm to patients, but also breeding resistance. And then there's really no standard length of treatment. So those were some of the things that we considered in those discussions. The reasons, of course, to treat infected contacts of MDR-TB cases. One, we hope that that treating MDR-TB while the bacterial burden is low is doable and could be done in a shorter time frame than when you actually end up with active TB disease. We would decrease the likelihood to progression, of course. And then, of course, that would decrease further transmission. And then the consequences of clinically active MDR-TB for the patients themselves, in addition to that factor around transmission. We did look in the literature, and I'm sure many of you know Simon Scoff and have seen his work in South Africa, along with the other pediatric groups there. They had published a couple of studies around use of fluoroquinolones in children for treatment of MDR-TB. So we felt confident about the use of fluoroquinolones. We've also seen some experience in the U.S., primarily around the use of either PZA and ofloxacin or PZA or ethambutol and a fluoroquinolone. And while I think these regimens have been shown, in the past to be, or at least in vitro have been shown to be effective, in vivo, one of the biggest problems is the tolerability of these regimens. And the example studies that we had seen, the majority of patients that started these regimens did not finish them or discontinued them due to intolerability. As you can see in the studies that we looked at, some of the median therapy was around 32 days or 1 month, which we don't think would be adequate. So those were all things that we considered. And ultimately, we came back to our objectives, which was to determine the feasibility of implementing this, because we knew in this resource-limited setting, it may be difficult to treat MDR-LTBI, but it is, we know, both deadly and very difficult to treat MDR-TB cases. So we wanted to make sure it was feasible. We wanted to come up with a regimen and look at its tolerability, and then, if possible, look at efficacy. Now, we specifically decided to not, I think both for ethical reasons and because of the underlying purpose in this situation. We did not want to risk a control group or risk a group where we knew they'd been exposed and not treat them. We just did not, again, both think it was ethically proper, and ultimately for the good of the program, we wanted to give everyone the best shot to prevent future MDR-TB cases. And so we did not specifically have a group that we could compare to, and we knew, because we did not have that group, that efficacy would be hard to prove. But as you'll see the results, I think there's still a compelling case despite the lack of control group. So our management plan was to treat MDR-LTBI by DOT for 1 year. We were to use fluoroquinolone-based regimens. The children were going to receive fluoroquinolone and ethambutol. And initially we discussed monofluoroquinolone use, and ultimately for the under fives, because of exposure and because of some of the complications we had seen in how quickly the children got sick, we opted to use fluoroquinolone and ethionamide for another group of the children. We conducted monthly questionnaires by field workers, many of whom were from the villages that we were working in, and they completed both symptom screens and they collected information on missed doses. And they were obviously providing DOT. They actually did it every day. They were in very regular contact with the patients, so they were probably assessing this information more than monthly, of course, but we asked them to record it by month. Every quarter, we'd have a visit by a healthcare provider, and biannually, we did a chest radiograph and a formal clinical evaluation in the TB clinic. We then attempted, and I think we're fairly successful in following the contacts for 2 years after the completion of LTBI therapy. That being said, there's only one TB program in Chuuk, and so it was very easy to, in essence, do a registry match, so that if other contacts had ultimately were diagnosed with TB disease, we would know about that. As I mentioned, we had 232 identified contacts. There was approximately a 6% attack rate during July 08 to January 2009. 5 patients were diagnosed with MDR-TB. Another 9 had developed MDR-TB while we were awaiting the procuring of the fluoroquinolone specifically, but the medications in order to treat MDR-LTBI. So 1 out of every 7 pediatric household contacts awaiting the treatment developed MDR-TB disease during that 6-month waiting period. So I think that's one of the things that really compelled us to be aggressive once we started to see this happen. 2 contacts who had not been identified during the contact investigation were also found to have MDR-TB. And again, this is where the limitation of that contact investigation was quite evident. There were family members that had come off island that said, oh, I'd been in the house for this time period, but then went away. And so I think both in the lack of communication and also in our lack of understanding at the time of kind of how the family structure existed between islands led us to neglect a number of contacts. There were 119 patients who are TST positive and had no evidence of active TB, and so that was the group that we began to work with. So the principles of LTBI treatment for contacts of MDR-TB cases: number 1, always excluding TB disease before the beginning of LTBI treatment. We did ensure that during the time that we procured medications, we wanted to make sure that everyone got a second x-ray, and we did, and we were aggressive about collecting sputum or doing a further workup because we did not want to inadequately treat what was active MDR-TB. We estimated the likelihood of infection with the risk of progression to MDR-TB, so we considered the exposure and whether or not it was significant enough for us to choose this regimen. We chose LTBI regimen of 2 drugs that were susceptible to the source case bacterium. And then, we knew that the efficacy largely developed on adherence and the completion of therapy, and so we wanted to ensure that we trained folks, and the program understood the importance of continuing that therapy. So just to go over our results of what we, after that first year, as I mentioned, we started 119, we offered 119 individuals treatment. 105 of them initiated treatment and 14 refused. And the refusal was for a number of different reasons, and I think I have a slide that'll go over that a little bit more. Of the 105 that did start treatment, we had 62 adults. 21 of those were healthcare workers. And I would say that, maybe obvious to the folks, but the 21 that were healthcare workers had, to us, the least defined exposures. We knew those that cared for these patients, but the quantity of time and the duration and the extent of the exposure was much less well defined. Often we didn't have any kind of charting to know which nurses or doctors or technicians were present at certain procedures, or if they were simply bringing meals to patients or things like that, versus those that were heavily involved in seeing patients day to day. We had some level of that, but the documentation isn't extensive. Of the children, there were 6 patients who were less than 5 years old. There were 20 patients that were ages 5 to 11, and there were 17 at ages 12 to 17. During the follow-up visits, as I mentioned, we conducted monthly visits with the 105 patients to look at occurrence of TB symptoms and side effects and make sure there was no progression, and also look at side effects of the medications, number of missed doses. And if you calculate roughly 12 months for 105 patients, you should have somewhere along the lines of 1,300 monthly visits completed, and we had 1,038 recorded, so about 82% of our monthly visits were documented. The post-treatment follow-up, at 18 months, we had 90% of our contacts. At 24 months, we had 50% of our contacts. And that drop has a lot to do with the time period. So at 18 months, there were more staff physically on the ground. We were able to both go to the villages and bring people to the TB clinic physically ourselves. Whereas at the 24-month period, both because of roads, weather, and varying reasons, we didn't have as many staff on the ground to assist in that process. And so we saw a big drop off at the 24 months. And because of that, we actually kind of redefined and re-stepped up our efforts at the 36 months to try and get as many people back to the TB clinic as possible. So we were able to get back up to 85%. So this is a slide that talks a little bit about adherence. In terms of treatment completion, of the 105 that started, 93 completed, or 89%. Of the 21 healthcare workers, 14 completed. So this is actually our lowest completion, was 67%. Now, I will say that there are a number of expatriates that work in the healthcare in FSM, and so they're folks that are from other countries or may not permanently live in FSM, and so some of that loss to follow-up was certainly due to folks moving away. And then of the children, only 1 child did not complete, and that was actually due to side effects. So of the 12 patients that discontinued treatment, 3 contacts became pregnant, and again, that's despite counseling. 1 additional patient restarted and then completed post-delivery. 5 contacts were lost to follow-up, as I mentioned, 4 healthcare workers, and there's 1 adult household contact who moved off island. And then 4 contacts discontinued due to side effects. 3 healthcare workers and the one child that I mentioned who had elevated liver enzymes. That child was ultimately diagnosed with hepatitis A, but neither the parents or the physicians at the time felt comfortable restarting because of the child's symptoms at the time that they had hepatitis A. And so ultimately that child did discontinue treatment. He did not, however, he had completed, I think, 8 months and has not gone on to develop active disease. And so I think we talked a little bit about this, but the healthcare workers' foot and joint pain was one reason, nausea, GI symptoms, and headache and fatigue. And I will say of the complaints due to the regimen, we definitely saw nausea, GI symptoms, and headache as two of the most common, and we have some slides about that as well. So procuring the second-line medications was a big challenge, and essentially, not only was there a delay, but there was challenges in ensuring that the medications were purchased most effectively. And I will say the FSM's relationship to the U.S. in terms of TB control can be a bit of an impediment in this regard, because many of the medications that were initially obligated to FSM for use had to be purchased in the U.S. And that, in terms of affording medications, became an obstacle. And so thankfully, the Chuuk TB program was able to work with Global Fund and others in order to procure medications outside the U.S., which became both more affordable and allowed us to have adequate medication to really step up the treatment of the contacts. So we talked a little bit about side effects. I just want to show you, we did look at what were the most common side effects reported by patients who did complete treatment. And about 15% of the monthly visits did report some type of side effect. There were no adverse effects other than the child that was hospitalized in terms of either permanent sequelae or hospitalization. The total number of side effects reported were 253, with the most common, as I mentioned, being nausea and headache or dizziness. We did not see significant tendon or joint pain, only about 4%. And lastly, I just wanted to show you this graph that Dr. Brostrom and I put together just to look at the timing of the side effects. And so as you can see, as you go across the months of treatment along the x-axis, you can see that there's a number of patients that may have discontinued. And so you can see that the dashed line here represents the cumulative percentage of discontinuation due to side effects. So then you take those out of the denominator, and really there isn't any kind of progressive increase in side effects, but it was rather more a sporadic kind of reporting of these side effects. And again, without any kind of adverse events or hospitalizations. And I believe with that, I'm just going to go to the conclusions here, which is that, although we did not design the studies in order to say anything about efficacy, to this point, there have been no randomized trials to show efficacy, and I think because of the ethical issues, it may be difficult to do that. And so it's hard with these lower numbers in this situation. But that being said, we had high completion rates. Regimens were very safe and tolerable without any severe adverse events. We did LTBI treatment by DOT, and that effort really is a measure of both the community involvement, the type of training and the type of investment that community health workers from the villages and the TB program in Chuuk, the efforts that were made to kind of get the community buy-in and have people that were trusted administer that treatment, I think cannot be underestimated. And that ultimately, none of the patients that were treated for MDR-LTBI developed TB disease. While we did have patients who were not treated who did develop disease. Let me just go back and highlight that because I do apologize. So I skipped a slide there. So no contacts, again, that were treated for MDR-LTBI developed TB disease, but 14 of those contacts that refused the treatment, 2 of them developed MDR-TB disease. And then there were others that were never offered LTBI treatment. As I mentioned, they were either not identified as contacts or they were lost to follow-up after the initial evaluation. And you can see that 12 of those developed TB disease, which is a significant number of people given this outbreak. So with that, I will turn it back over to Dr. Brostrom, and thank you for tolerating my laryngitis.
Thanks, Sapna. Just wanted to add with this slide that that we also used this the treatment schedule as an opportunity to try to look more closely at the pharmacokinetics of levofloxacin in children, and that's a paper that's pending and hopefully will lead to improved recommendations for the use of levo from the published dose. So when we look back at the efforts from in Chuuk, we wanted to try to take a systematic look to see why we may have achieved success with this process that seems more controversial in other areas. And honestly, I think we have to report that we did have additional funds. We had $2 million. Most of that went to treat the cases. I think the additional cost and workload to do the LTBI was incremental. We had Chuuk State declared a public health disaster with this MDR-TB, and that helped us with procurement and really sped the processes along that can cause delay in all countries. I think from the beginning we were focused on reestablishing a DOT for the program. This wasn't an MDR-TB response. It was a programmatic upgrade all around, and in the end, those improvements for the entire program aided us in our efforts to try to eliminate MDR-TB there. Again, the costs, unfortunately, we did not calculate them, but we do feel like they were incremental. I wouldn't type this in, but the estimate was maybe around 20 or 25% of the cost went to managing those contacts. As Sapna mentioned, the folks that were delivering meds in the village and keeping track every day were, of course, well trained and instrumental to the success for us. I also think it was important that operationally that from the beginning we designed this to be a best practices model. With the limited information we had on MDR-LTBI in the literature, despite our desire to have great data, we felt like this opportunity was more for doing our best in the setting rather than necessarily creating a randomized control trial. We certainly didn't have the numbers to do that well, and we had a high need for this population. So again, that does affect our ability to say a lot about effectiveness, but in the end, this may be more about efficacy and feasibility. The forms, I think, were important, and part of the teaching and training for the healthcare worker staff in Chuuk was to create checklists so that things could be done in an organized fashion, and which helped us in looking at the statistics afterwards, but more importantly, I think helped to drive activities every day so that the job was done well with the highest quality LTBI we could bring. So we actually have some of those forms that we used. They were initially 7 pages long. When we got them, we amalgamated forms from the States. We sort of boiled it down to a 1-page, and we should be able to include those forms for you if you wanted to edit them and use them in your setting. As we mentioned, training was important, and I think the key is to do hands-on training. You can't do this from a distance. For a fragile TB program, we spent a lot of time in Chuuk. And training went to the clinical staff, but it also went to places like the accountant for the government program, the Secretary of Health, a couple of politicians. We had to really build the kind of political will you need for change and for improvements. We also had monthly case reviews by the phone, and that's certainly something that all programs can do. It would be silly for us to talk about any success in Chuuk without mentioning prominently the local Chuuk staff, who are really phenomenal, hardworking, dedicated people. This is Dr. Fred. She's received a couple of awards, but still is one of the most remarkable TB clinicians in the Pacific. Just an amazing person. And we're nearly done here. We just also wanted to mention that the attention that was brought to Chuuk also helped in our entire region. We don't want this to happen again. And we have improved MDR capacity across the Pacific for all the 22 nations of the Pacific, particularly the 6 U.S. jurisdictions. We've created a Pacific second-line drug stockpile using global funds. That is so that no specific country has to stock these and have them ready. And when Palau had their MDR case 2 years ago, they filled out a 2-page form, made a couple phone calls, and 2 weeks later they were able to initiate treatment for their MDR case, which is a remarkable improvement in a pretty short time. Unfortunately, that stockpile is not for prevention yet. There's a multi-agency MDR-TB support network that we've put together in the Pacific that works very well. And the time to diagnosis has been remarkably shortened by the acquisition of gene expert systems that we are putting in across the Pacific. It's a good platform for a small island. So putting out that fire in Chuuk was a daunting task, particularly in 2008, when we had 5 who had died and 15 new cases, 21 more cases that had not yet been diagnosed, and more than 100 infected close contacts that were identified. I don't think anyone is courageous enough to say the word elimination yet. I'm a little too superstitious to say that, but it is comforting at this point to know that we have completed the last known case of MDR treatment, but no new cases for the past 2 years, and we've completed treatment of more than 100 known contacts, with no cases emerging from that group. Lots of people to acknowledge. I think we've left Rin Song's name off of this list, which we shouldn't have done. He was fantastic to work with and was made several visits to Chuuk to help us with this process. Let's move to the poll section if we can. We'd like to ask you a few questions for those who are listening. This is informal, all right? Nobody's going to be held to this. And we'd like to find out what your opinion is about the feasibility of MDR-TB prevention for the listeners. So if you could log in for these questions, I think it'll sort of help us to develop consensus as we move forward. And we really would appreciate your opinions about this. We know that MDR-LTBI, even in pediatric household contacts, is still a little controversial. So we'd love to hear what your opinion is. I promise we won't chase anyone down for their specific answer. Let's go to the next question, okay? There's 22 logged in there. Second question is like the first one. For most TB programs, MDR prevention just takes too much time. The MDR-TB uses staff time that we need for treating regular TB cases. It's another common criticism for trying to do MDR-TB prevention. We got 19 so far. There we hit 20. So I think we can move to the next question. Okay. So for most MDR-TB settings, MDR-TB reinfection will make MDR-TB prevention ineffective over the long term. another common criticism, and quite frankly, I don't think we know what that answer is. All right, there's 19. Let's go to question 4. I've heard this a couple of times, and so I'd love to have your opinion here. With what we know now, obviously there's a couple of big studies going on. MDR-TB prevention is just still too risky. We use unproven and potentially harmful treatment strategies. Thanks for providing your opinions, you guys. Okay, question 5. Now we get to pretend we're the boss of the world here. If I could make a policy decision for my program, I would do one of these. Take a look at those and select your best option. All right, there's 20. Go with the last question. This one's a little trickier. All right, in your opinion, and with our present level of knowledge about treatment for TB infection, WHO and CDC should endorse treatment of pediatric MDR-TB contacts. Sorry to push your opinion into one of these boxes. I'm sure there's lots of room between A and C for other options. All right, there's 20. Great. Appreciate that information, and we'll try to make that sensible. At this point, I think we should back Virginia, our moderator.
Sure, thank you so much. I think we have at least 2, so if you wanted to address those, that would be great. And if anyone else has further questions, please feel free to type them in the questions for experts, and we'll take them as we have about 5.
Jen, and formulation. The liquid levo, I believe, was a 20 mg per kg. That's from my memory. I probably shouldn't even say anything, but I'm pretty sure it's 20 milligrams per kilogram, and I'd be happy to get the actual answer for that for you. And we dosed it at 10 to 12 milligrams per kilogram initially, and then we pushed that up at the end, closer to 15 milligrams per kilogram for the dose. Sapna, you want to take the second question?
Sure. Hopefully you can hear me again. So I think Jen had asked us, we comment our decision to include older children in the LTBI treatment, even for IPT or IH preventive therapy. Most programs tend to focus on under 5 and HIV infected. I think, again, for us in this situation, of the initial 5 patients that were diagnosed with MDR-TB, we had a 2-year-old that passed away, but the other 3 of them were adults. And then there was 1 teenager who was diagnosed with MDR-TB, but was still living. And so I believe, I think given the situation and knowing what it took to establish now what ultimately has been very successful care of MDR-TB patients, at the time I think we were very interested in preventing as many cases as possible, and we truly believed, given the amount of exposure and what we saw in terms of progression to disease, that treating household contacts, even if they were adults, was both feasible and would prevent cases. And so I think
in this setting as well, Sapna, I remember that the secondary cases that we found were generally the caregivers for the initial 2 patients, and that would typically were appeared to be the family members, mostly female, who spent a lot of time caring for the initial infectious MDR cases. So we think that there was a fairly significant exposure even in that population of teenagers.
So I think, I think so. We, of course, our priority was to treat the under 5s and the teenagers as well. I mean, any of the pediatric contacts were definitely a priority. I think we were more aggressive in terms of the folks that refused treatment. I think there were no children involved in that, so I think we were very we concentrated a lot of efforts in education to parents of children who have been exposed. But I think that in general we looked at the whole population as being at high risk, and we wanted to prevent as many cases as possible. That, and a lot of the places, or a lot of the families that ended up taking LTBI treatment were just that, were families. So we had children and adults that we thought were significantly exposed, and so we wanted to offer that preventive treatment to the entire family and not just the children. And then Dick, I'll let you take Jen's other question about the fact that IPT has been shown to be effective, but almost nobody does it. So what do we think it would really take to do preventive therapy?
Well, I think it's the same things that, this is totally your opinion at this point. And I think that because it's other resources required, particularly in time and as well as medications, and I think it's just hard for programs to prioritize this in their list of day-to-day activities. So I think there has to be some political will, and there probably has to be some additional resources that's devoted to allow us to do this on a larger scale. I think those resources can be modest, but I think they should be targeted for MDR-TB prevention. And if we ask programs, if we're just going to simply ask everybody to work a lot harder and do this without any additional resources, we're probably not going to get very far. But I think the success comes from determination and organization. It's not rocket science, and this program that did not have a lot going for it in the beginning did very well with it in the end. I'd like to talk to the next question about, did contacts also receive some food support, etc.? The contacts were given a voucher eventually. Most of them didn't get anything in the first 6 months or so, but for the last 6 months, they received $5 per patient per month if they achieve 90% compliance in that month. And I think the willingness for the program to continue to deliver high-quality preventive therapy probably, we're quite sure that incentive improved our compliance. The next question, Sapna, would you like to take that one?
Sure, sorry, I was trying to unmute. I think the question is, did we consider sources resistance patterns for preventive regimen selection? Is that meaning?
Yeah.
Okay. Yes, we actually, we did consider the source resistance pattern. So as I mentioned, we identified 2 different outbreaks. They were geographically separated. One of the outbreaks, when we looked at historical TB cases from the same village, so there's a fairly tight-knit village. There were probably 30 to 40 families in this village area.
I think we just lost Dr. I see that it is.
Okay, now Sapna, you still there?
Sorry.
Yeah.
Am I here?
Okay.
Okay.
Yep.
So when we looked historically at the one village where the 3-drug resistant MTB was identified, we saw that there were over 20 INH resistant cases documented in that village prior to the MDR TB bug that was identified. So we knew that there had been drug-resistant TB in that village for quite some time. There had also been a number of TB deaths in that village. And so I think while the cases, one case that had died and one case that was living had MDR-TB, we also knew that the burden in that village had been at least for INH resistance in that community for some time. So we did take that into consideration. We knew that the fluoroquinolone may have been adequate, but we knew also that none of the bugs in that village in the last few years had been ethambutol resistant, and so we opted to use 2 drugs, and then we chose that regimen. In the villages where we saw the 5-drug resistance pattern, we used fluoroquinolone alone in the adults, and again we added ethionamide for the children because we wanted to be particularly conservative and make sure that we were adequately treating the children because of their high risk of progression. I hope that answers that question. Rick, you're on for the next one.
The next question. Okay. The next question asks about how our results may translate to a place like South Africa with a high burden of HIV and TB. So in that setting, would we consider using INH in case there was exposure outside the home? I think the answer to that's pending. We know there's a couple of big studies, I think one in Vietnam, one in South Africa, doing MDR-TB prevention using single drug therapy, just levo, and just for 6 months. I think that I think we should expect that this is going to have a positive result. I think we probably were overcautious just because we were new at this game, and we're eager to see how these turn out. But I think that adding INH, I think that levo is quite effective against pan-sensitive TB, and so probably we would not necessarily add INH in the settings where there was exposure outside of the home. I think the levo still would be the drug to go to in a setting where there's mixed HIV or mixed pan-sensitive and resistant tuberculosis. Of course, if it was XDR, we would not expect that to be an effective regimen. Sapna, do you want to take the next one?
No, I'm going to have you take the next one, but I do want to add something about that, Jen, which is that I think, whether it's HIV or diabetes or other medical conditions, I actually don't think that would necessarily change my approach. But I think one big thing that's different in South Africa or India or China or other locations is the possibility of reinfection. Where we were working That possibility existed, but was very minimal. And that's one because the number of cases, once they were identified, they were brought into a facility and removed from the home. And because of the relative ability to, for example, x-ray the whole family relatively quickly, we could feel assured that there weren't a lot of other possible cases that contacts are being exposed to. I think in South Africa and some of these other settings, my bigger concern would be the possibility of reinfection, in the face of 6 months of preventive therapy. And I don't know the answer, but I think that would be what would most weigh on my mind.
And great, and then question 6 here is a fantastic question. It talks about DST patterns they take 8 to 12 weeks to be returned to the program. Is it better to wait in the pediatric household contacts until you have the DST pattern of the source available to start treatment, or can a standard regimen be started? So this is a standard regimen for prevention, I presume, is the question. And there are, I don't think the answer is going to come easy. I think it's a matter of opinion and whether or not you have an expert or some reason to think that you've got an MDR case that your pediatric household contacts were exposed to. For me, I'd probably try to wait if I had an expert result that showed rifampin resistance, and I knew this was not a place that had pre-XDR or XDR. It would be reasonable to first, of course, rule out active disease in that child, and then initiate treatment for LTBI. But probably by the time you've effectively ruled out active disease, you're going to be close to that time you identify that you're going to have a DST. At least I would hope so. I know there are many places where a DST is simply not available, and then it's more likely that you're going to have to make a decision in the.
All right, I think that was our last question, and we're perfectly finishing on time. So I wanted to thank our wonderful presenters today, the participants, for great questions and being very engaged. And as was mentioned before, this webinar was recorded and will be available